Okay, so starting with chapter 22, this is for bowel and bladder elimination today's lecture. Another big part of nursing. Just like when we check vital signs, that's our way of measuring stuff. What's going on inside the body. We have to measure the bowel and bladder by certain ways too. We can't check a vital sign on a bowel or bladder, but what can we check that we can measure? Intake, how much they're drinking, and how much they're putting out, the output, right? So, that's too long. Where's the? Does anybody have a marker I can use? They're all gone. I don't know what happened to them. Every one of them. That's irritating. Can y'all see this in the back? Alright, so when you have the bladder, this is your, get him up here for a second. No, you're fine. You know, in our skeletal system, we talk about the pelvic girdle and the suprapubic bone, right? It's right here where your pelvic girdle attaches to the other pelvic girdle. That's your suprapubic or your pubic bone. Sometimes that's when I have to break open with ladies when they're doing proper. So that's your pubic bone. Supra means what? Above. So right above that pubic bone, suprapubically, is the bladder. Let's see if I can take this out without it falling apart. And the bladder is just a pouch, kind of like your stomach. They can stretch. What kind of muscle is it made out of? Smooth. Real smooth. So it's sitting right here. And it has a little, I'm going to pass it around. It's really small, but it can stretch. Okay, so see how the lining is just like the inside of the stomach, it can stretch. And then it goes out into the rest of the, so here's your kidneys. And then you have these little tubes, ureters, and they connect to the bladder. They drain everything into the bladder. And then you have the urethra. In women it's smaller, right? In men it's longer. And so that's how the urine exits the body, through the bladder. Okay? Now when we're putting a catheter in, we know that has to be sterile because we don't want this to become contaminated. So we've got lots of different kinds of catheters. Main reason why we're putting a catheter in sometimes is, one, the doctors order it because they're unconscious, or they need extremely strict, I know, we have to know exactly how much is taken in and exactly how much is coming out. And so they'll have a catheter for that. Maybe they're completely incontinent and bladder, urinary bladder, over urine. And so they'll just have to have a catheter. It just depends on the situation. You know, a lot of times it's mainly, like I said, as a measurement. It has to be sterile because we don't want to put this into a body that's already sick and expose more germs, right? So we're going to keep it sterile. Lots of different kinds, and I brought a few to show you. Okay? The coude, and it's named after the guy that, I guess he was the guy that did it. It's a little bit more stiff. It's kind of almost got like a wire in it. And they use these for people who have an enlarged prostate. Because in a man, by the way, women, we do not have a prostate, right? You know that. We don't have one. Only men. And in a man, that prostate is, let's say this is their urethra, right? Comes out. The prostate is almost like a little donut that encircles their urethra, okay? So that when that prostate gets enlarged, it starts swelling and pushing on the urethra. So it's just like a water hose that's being pinched or crimped. The urine can't come out, so they'll just have a little bit of a trickle of a urine stream. It's real hard for them to get started. They can't, you know how usually you can hear a man, they sound like a fire hose when they're in the bathroom. They're just barely trickling. pushing on it. So they use what's called a Coudet catheter. All right? Yes, for an enlarged prostate. And I'm going to pass it around so you can feel the difference in them, okay? These are Coudets. They're a little bit smaller. They go at your Foley in the lab. And they're a little bit stiffer, okay? So that's a Coudet. And then here's a Foley. Let's go ahead and open it. This is one that's not connected to the bag yet, okay? Because you can get them just like this. So see the difference? It's like a wet noodle, right? If we took that Coudet out, the thing stands straight up because it has a wire in it to make it stiff so that you can get in and go around that enlarged prostate, okay? So here's your Foley, so you know the difference. And if you look on the side of the Foley, remember I showed some of y'all, it tells you the size. On this little orange tip, it says 16 French. The part where you blow it up to blow the balloon up, it'll tell you the size, 16 French. 18 French is normal that we usually use, okay? It's the one that we use in the skills lab a lot. It's the standard that a lot of people use if they don't have any issues. You put it in, you inflate the bulb with how many cc's of saline or water in, and then you gently pull back to make sure that it's anchored in the bladder so that it will stay in the bladder. We have to, again, be very sterile with that. When we put it in, if we put it in the wrong hole, can I just, oh well, and keep going? No, what do I have to do? Throw it away and start with a fresh one. And here's your landmarks, just so you know, for your anatomy. In a female, you have the clitoris, then you have the urethra, a little bit bigger, and then you have the vagina, and then of course you have the anus. Right? And these are the internal labia, and then you have the larger external labia out here. Right? So, when you're going to insert a Foley, you always want to make sure that you're getting your landmark straight first before you actually insert it. Because once you put it in, if you're in the wrong hole, there's no going back. You got to start all over. Y'all know what a pain the sterile field is, right? You've already experienced how hard it is to stay sterile. So you go and you're not sterile yet, you're just looking, and you go ahead and visualize looking for your landmarks. The clitoris is always at the top. You can tell where the anus is. The vagina, usually it's pretty visible, you can usually tell. So really all that's left is the one right in the middle, right? Clitoris, vagina, there's your target, right in the middle. The urethra. This tiny little hood almost is covered. The body covers it to keep germs out. So you have to really open your patient up, get some assistance, and use your betadine and really visualize it before you insert the Foley, because we want to make sure that we're going in there. Now once the Foley's in, what do we watch for in the tube? Urine. Right, we're looking for urine and know that we're in there. Okay? So just make sure that when you're doing your Foleys that you're keeping them good and sterile. Alright? And then there's lots of other different kinds, and I think this is in your book on one of your pages. It shows all the different kinds of catheters. Yeah. What page is it? 662. Yeah, 662. You can kind of see they have just different tips. And again, that's just for different kinds of anatomy. Sometimes the doctors order them, older doctors, they still used to use those, and so they'll just continue to order that. Or if they have some kind of special urinary issue, that the structure of their bladder or their urethra is different, they'll use those. Okay? But for general purposes, just know a catheter of any kind has to be sterile, and that you're going to be using it to measure urinary output. And a Coudet is the one that you use for an enlarged prostate. Those are your real common ones. Okay? This Robinson one has the multiple openings, because that's one we use when somebody has had an enlarged prostate. They go in and they do a TURP, transurethral prostate resection, and they pinch this off, little bitty pieces, little alligator clamps. They're going in through the urethra of a male and pinching their bladder, their prostate. And so it's real big, thick chunks, it's bloody, and so you have to irrigate. You'll have a big, huge bag of water, sterile water or saline, and you're irrigating through the catheter. It's not going into their IV, it's through their catheter to flush all those blood clots and stuff out. And so that's why you'll need one, because you have to have extra fluid going in through that port, but then you also have to have one that lets the urine and the extra fluid come out, right? So that's why they'll have that one for irrigation and stuff. Okay? And then there's some that are super long that go up even past, because normally here's where our target is, right? Once we put the catheter in, so that it sits right there at the neck of the bladder. And then sometimes they have one that has to go even higher. So it's longer so that it can go into these urethras. Why do you think we would need one for that? Think about your anatomy. Do what? No, your adrenal glands are on the top of your kidney. If this was, normally it's open like this, but let's say they have some kind of damage. Maybe they had a lot of kidney stones, or they were just born with it extremely small. So how much urine do you think can go through a big opening like that? A lot, right? How much do you think can go through the size of a coffee straw? Not much. So they'll use those longer catheters to go in, and it actually goes into there. That way you open it up and can let the urine that this kidney is making get out. Otherwise, it's just so tight in there that no urine can get out, and this kidney constantly stays infected or irritated.
How do you know that you're inside the treatment?
See what?
How do you know that you're inside the treatment?
Usually they've done an x-ray already or some kind of test, and they know that this is the area of problem. Because they'll start here. If this is all okay, the prostate's okay, the bladder's structurally okay, they look at the ureters. Oh, this one's extremely narrow. You know, it's like this compared to this. So that's when they realize, okay, here's where the problem is. This is the blockage. This urine can't get from A to B because this tube here is too small. So they'll put a longer catheter in there. They do it in surgery, and they have surgery. But you'll know, I want you to know of it, because when you hear urethral catheter, you know it's way up high, right? And you're definitely going to have to be careful with it, not let it get snatched or pulled, because you could do more damage to their anatomy. And you know that you're going to have to really, really, really watch that trick I know, okay? So they're super long. Let's see if I have one. I don't even know what I would have in here. Oh, here's a good one. In males, they have what's called a red rubber catheter. And so, let's say you're doing a quick urine. Has anybody ever had, ladies, one of those little quick in and out catheters? It's in a little tube. It's like a teeny tiny little straw. They stick it in, the urine fills up the little tube. It's like a blood tube. They send it to lab. You're not going to keep a catheter. They just want to do a sterile urine sample. That's a quick in and out. For men, you can't do that because the straw on those is only this long. They're probably, excuse me, the catheter is only that long. So in men, anatomically their urethra is longer, right? So we have to use a longer one. So we get a red rubber. And look at that. Yeah. It's just long. It's huge. However, this is a 22, so it's not as smaller, really. But this is one that you can just go in and out. It doesn't have a place to blow up a balloon because it's not going to stay in there. We're only using this to go in, drain our urine sample into the cup, and then we take it out. Okay? So there's that one. Red rubber. Red, yeah, it's on the. It's called red rubber Robinson catheters. Yeah. We just call them red rubbers. Alright, so just know there's lots of different kinds. Like I said, it's in your book. There's whistle tips. They're in the book also. See that on page 62? It has a slanted, larger orifice at the tip, and it can be used if there's blood. So, like, we know blood clots, right? It's not going to go through, so we need a big one. And then there's things called the suprapubic catheter. And these are pretty intense. I had to have one. I had had a hysterectomy, and they didn't do something right. And so I started having problems with my urine leaking in all the wrong places. And I was going, this isn't normal. It took me 6 months to convince the doctor that this is not normal. This is not happening. He kept telling me I was having stress incontinence and all this other stuff. Not true. And finally, after 6 months, I literally told him, I'm going to kick you in your teeth if you tell me I have incontinence, because I do not have incontinence. And I'd already been through 2 other surgeries to correct his error to begin with. But what had happened was he had, when he was doing the hysterectomy, he sewed through my bladder with the sutures and into my vagina. He was sewing up my cup. And so he created a fistula. A fistula is a hole. It can be anywhere in the body. It can be in your heart. We have fistulas everywhere. They can be a rectal, between the vaginal wall and the rectum. There can be a fistula there. You can have between the vaginal wall and the urethra, or the bladder. And that's what had happened with me. He had created a fistula, and I was having this trickle of urine coming out the wrong place. And so, what they had to do to go in and repair, I told him he would never touch me again, and I got my records and left and went to a real doctor that knew what he was doing in another town, and he had to do a suprapubic catheter, where they actually go into puncture, like we talked about, a little sterile procedure, and they puncture through your abdominal wall into your bladder, and then they insert the catheter in there. So for 3 or 4 weeks, I had this tube coming out of my lower abdominal area, and it looked just like a Foley, except it went into my abdominal wall, because he had to repair the hole that the other guy had made, and if you have a Foley, that's just going to keep rubbing on that suture line, and it never would have healed. So you had to put the catheter coming here, outside of your body. So you'll see, until the other could repair it, you will see suprapubic catheters in people who have had some kind of damage, or their anatomically structure is off, or they've had some kind of surgery where they're trying to repair that, because it takes the pressure off of the incision in the urinary anatomy. And so eventually, I was like, the first thing when I woke up, I was like, oh my gosh, how am I, I have a hole in my belly now, in my lower abdomen. It looks like another belly button. And I said, what's it going to do? How am I going to, when you take it out, is there going to be a hole there forever? Am I going to have to put my finger in it to not leave? What, And he's like, no, it's amazing. Our bodies are amazing. It closes right back up. It seals itself off, and then it through granulation, it filled in, and now all I have is this little tiny little scar right there. You do. I should have, but the world of karma I believe in, and so I didn't want to, because I thought my luck, I'd sue him, and then I'd mess up on somebody and they'd sue me. So I should have. I went over my records, and I was like, this is every indication of what happened, and he absolutely just would not listen, because they're arrogant. So anyway, just know that people with suprapubic catheter, it's coming out of their abdominal wall, okay? And it's to allow the healing of the other. You don't need to know all of them, but you do need to know what they, like suprapubic is important, because you're going to see that a lot, especially if a man's had a prostate resection, because they can't put a catheter in here for long if this is not working, so they'll put it right here, coming out. So it can be male or female that have those, okay? So don't think that the catheters can be through the urethra. They can be through the abdominal wall. Okay, and then you have a condom catheter. Okay, have y'all seen one of these yet? If you work in nursing homes, you may have seen a long-term care.
Is that Texas catheter?
Yeah, Texas catheter. This is it. It's sterile. Well, they're sterile to come with, but it doesn't stay sterile because it's on the outer part of the anatomy. So let's say this is our penis, and you put it on, and you're going to roll it up. And then you connect your drainage tube to that, okay, to collect the urine. Now, that is all fine and good as long as you're firm, right? But how many of your patients, when they go to sleep, are not going to stay erect? So guess what this does? This thing shrinks down to nothing, and then it's kind of sticky right now because it's old. It's meant to be sticky when you first put it on. Look, that's not staying on there very well, is it? And then it's not even this long. It's like this long. Sorry, Joseph, I'm not meaning to look at you. I'm trying to what I got. I'm trying to read the room. So just know that those are not sterile because they're on the outside of the anatomy. They're not invasive. So are we going to have less risk of infection with a condom catheter? Yes, because we're not putting anything in them. But just so I wanted to show you so you know that that's a condom catheter, and it connects. The tubing would then connect here to a bag, just like a Foley. Okay. Don't get too excited touching that, young lady. So.
That one's more risk for.
No, they have less risk of infection because it's outside of the body. It's not going in. It's external, so it's not going into their body. 6 degrees. people are getting away from Foley catheters in long-term care. You know, we talked about that because they're not getting reimbursed for all those UTIs, right? So, somebody who is just not continent or they're having problems where you need to find out how much urine, trying to be more measure it closer rather than in their briefs. You can't really ring it out, measure it in the brief, but you can if they have a catheter. So you can know exactly how many milliliters or mLs they're having if you have a catheter. Well, we can't put a Foley in him because he'll rip it out, he's confused, or he'll get a UTI. So that's when these come in handy. But they don't stay on very well either. So
Are there different sizes, like they're all together?
yeah, there's different sizes like in the bathrooms, yes ma'am.
Well, no, I mean like with
Yeah, they have different.
Trojan, really?
See, it says size small. So
You can tell that was small.
I guess they do. I'm sure there's people who need them. They really need to be small because they sound anyway. But then you don't want to constrict blood flow to any appendage. Alright, so just like I said, those are for incontinent males. But what do you think the issue of, it's less risk of infection, but what do you think that's going to do to their skin? Constant exposure to urine. It's going to be a breakdown, right? So you got to watch real carefully for skin ulcers there. That's a tender area. Okay, and then there's people who self-cath. These are your people who've had their car accident and they're paralyzed from the waist down or whatever. And now they've gone through rehab, they're at the hospital, they're stable. So we're sending them home and they may have a home health nurse at times. But you have to teach them how to self-cath. And they'll just take their little kits, you've probably seen the commercials on TV, they can order those self-cath kits and you teach them how to do it as sterile as possible. Work. So anyway, they just learn how to do their own thing. They self-cath. And your job as a nurse is to teach them the best possible sterile things. Right? So they're doing that all. Yep, they learn how to, you have to teach them. You have to get a mirror and show them the landmarks and they get used to doing it. Because they can't feel it because they're paralyzed. They have to do it. I mean, that's why we teach them. Because they really can't feel it. They can't feel it. So yeah, they could actually scratch or pull or hurt something and they get inflamed. And then they don't have any urine output because like, your urethra is clamped off from all the swelling. So it's important to teach good technique and about infection when you're teaching your self-cath patients. Okay, and it's to give those people independence, right? This is a young person. Let's say you're 25 and you got a car wreck. Do you want somebody looking at your personal business 3 times a day? That's still a big issue for them, and so this allows them to still feel independent and not so invaded. Does that make sense?
oh, so they just do it.
They do it self-cath. They do it.
Well, and then they don't do that. They just do it.
Yeah,
and
and
then
you get into a receptacle, bigger. Okay. Some do, but then, like I said, then they are a risk for infection, right? And we're getting into that reimbursement thing, so they just learn how to self-cath. All right, so we know our routine cath care. Most of y'all did this already in lab. If you hadn't, you need to get in there and practice. Perineal care and clean the first 2 inches of the catheter every 8 hours. So when you're going to see your patient, you're doing your initial assessment, you're looking at them, listening to the breath sounds and all that. You know, the first couple of inches of the catheter that's sticking out, we want to clean good, right? So this is in the body. We just get our cleaning thing, whatever your facility says, and we clean it. We take our cloth or a rag and we clean it out. It might be what are they called? The iodine swabs. We used to use those at our facility. We just swab the catheter and then take a sterile 4x4 and do it like that. Every shift. And that just keeps these microorganisms that are crawling around on your leg. Because look, they can just crawl right up there and get right into the bladder, can't they? So that's part of perineal care, is clean the first 2 inches of the catheter that's exposed outside the body every 8 hours. You don't want to use powders or lotions. Why do you think that is? Would that be a media or a vector? It can harbor bacteria. Okay? And then while you're looking at that and you're cleaning, you're also, because you know, nurses multitask, we do 10 things at once. We're looking to see if their urethra is intact. Does it look real irritated or red or painful? And then making sure that you're looking at the urine in the bag and in the tubing. Does it look really cloudy and dirty and full of white blood cells? If so, what do we need to start working on our shift? Pushing fluids on them. Make them drink more to flush all that out. Check their temperature to make sure they don't have a fever already. Okay? So you're going to be looking at that. You're going to be looking at the color of the urine, the odor, any kind of leakage around the insertion site, and then anything in the bag that looks not normal. Okay, and then you can do bladder training where we, just like a toddler, every 2 hours or every hour you take your patient to the bathroom and you let them sit there. And they go, maybe, then they go. So you can do bladder training. Just help them manage their incontinence. It is, I can speak from first-hand experience. It was a horrible experience having to walk around with these poise pads on all day, being a mom and a wife and a nurse. I felt like I was so obvious to everyone else that, and I was worried about smell funny. And every time you get up, stand up, you feel a gush of urine, and you're thinking, oh my God, did I just leak on myself? It is such a body image issue, and it's such a personal thing that you don't tell anybody. And so they become very depressed. So your job as a nurse is to help them with the scientific part of it, but also with the emotional side, the support side. Okay? And then if they're not going to have that indwelling catheter forever, you would teach them, about how to do self-cast. Okay, that's not for us. How many milliliters of fluid do you think we need to have to prevent the need for excessive catheterization? 2,000, that's right. I'm going to give them that, daily. That helps keep them flushed out, keeps things working. Alright, so that's that for chapter 22. Here's a urine sample cup. I think everybody had one of those one day, didn't we? So if you ever had to get, a sample from a patient, you give them the cup, you do a clean catch where this has a little cloth in it, and you wipe. Which direction do you tell your patient to wipe in? Front to back. You ever go back to front. Okay? Front to back, and then let them start peeing a little bit to flush that urinary tract. Then they get the collection sample, and then they finish voiding in the toilet. They have little, in the kits, or sometimes facilities have like a little sticker that goes to their leg, and it has a little Velcro loop. And so you would Velcro it to their the tubing to that Velcro. So you don't want it to be tight. You don't want any tension on that catheter. Has it on their stomach? Okay, so just know a clean catch doesn't have to be a catheter, right? You're literally just catching the urine, like a drug screen or a urine sample in a clinic. Just make sure they wipe front to back. What do you do if it's a baby and we don't want to catheterize a baby?
You put that little deal on, stick it in.
Yep. Take this little bag. It's called a pediatric urine collector, and y'all can open this and see what it is. It's just a little bag that you, while they're in your care, they're at the hospital or ER clinic. It has a little sticky thing. You just peel it off and you get it on their anatomy. You stick it to their anatomy, whether it be male or female. And if it's a little boy, you put his penis in that bag, and if it's a little girl, it's right there stuck to the external labia, so that when they do void, it catches it, and then you've got a sample. See? So this would be the part that you peel off and stick to them. Okay? And then it catches it either way. If it's a boy, you're going to put it in there like that, right? And stick it to them. If it's a girl, peel this part off and stick it to her anatomy, and it catches it for you. Right? And that prevents you from having to catheterize a little baby, and that is not fun. It's horrible. And, again, you're worried about scratching or hurting them because they're so tiny. We could perforate their little, their anatomy is a lot smaller and shorter than ours. So just know that those are available. That's a urine collection bag. Sometimes you can use those on your little elderly ladies too. Some, just depends. Last ditch effort before you have to catheterize them, just to get a sample. Okay. What else do I want to see all about catheters? y'all know what urinary retention means? Let's say my bladder is full. It's so full of urine because my kidneys are making urine. They're working fine. My ureters are working. They're doing fine. And then my bladder is holding it. Cyst is bladder, right? Y'all know that. So now you've got this just a pocket. It's just a pouch that holds your urine. But something right here is either not working, or there's a stone here, or there's some kind of structure like I had that was not letting your urine get out. And so that's retention. Anytime you're retaining or you're having urinary retention, that urine is just sitting in here. Okay? So let's say it's a male and he has an enlarged prostate. Now this is swelling and pinching, so he's just got drips coming out, right? He can't get all this urine in here out because this prostate is blocking him. And so he'll have urinary retention where he's retaining urine. He'll get a little, he'll pee, and a little will come out, but he's still here. But guess what happens? More comes in every day, all day, right? So then he fills right back up. So it's like he never catches up. He pees a little bit, but he's constantly refilling it, right? So urinary retention is when you can't get all that, you can't empty your bladder completely. We talked about bladder training. It's just like you would for a toddler. Every hour, every 2 hours, you and the CNA or whoever work together to try to get that done, okay? And we all know that if you're incontinent, that urine or bowel movement that sits on skin is horrible, right? It's horrible for your skin. So we need to do really good skin care in between. Whenever they have a bowel movement, or as soon as possible from a bowel movement or wet diaper. We do not want someone to be in a wet brief all day. Yeah, it just sits in there like it does in a urinary Foley bag, and that's when they get infections. Yeah, overflow is like it gets so full that eventually it just pushes out. But it normally won't with the prostate. But anyway, with an elderly patient, like let's say some of the meds cause urinary retention. Have y'all learned those in pharm yet? There's some meds that absolutely, like especially diet pills, they do not, they help do something to the bladder. Remember, it's smooth muscle. So if it's real tight and it's stimulated, it's not going to relax to let you empty it. So they can have retention, and then it gets so full that it's like I can't hold anymore, and it just you push it all out. It pushes out, which is retention and stress incontinence. All right, so everybody has looked at a bag of Foley in the lab, but here's one that has, these are more like an ICU. It has this like real detailed. These are the ones you empty every hour. So it gives you down to the special, like not just 100 cc's, it's like 20 or 30 cc's. It's more precise. There's that one going around. And this one just says it's with a 200 it only holds 200 milliliters in the box. That way you know, like when you're doing hourly inos or every 15 minutes, you know exactly how much they've had in an hour. Okay. I think we got all of our catheters. So all of that is in chapter 22, the urine part. Okay. Now let's get to the poo-poo. Quick. That one is chapter 30. What is it? 32. Yeah. And there's only a few pages of this chapter too that you have to know. We already know that part of aging, everything's breaking down, right? That's just part of it. Well, in the gastrointestinal, that's your stomach. Your gastro is stomach. Gast. So like gastritis, gastro, that all means stomach. And then intestinal is your intestines. Small intestine and your large intestine. And so, as that body is aging, this is muscle too, so it's going to age. body didn't need to absorb, it says, okay, I'm done with it, and it pushes it through the colon to be excreted as waste. Right? So small intestine's absorption, large intestine is just excretion of waste. But with age and lots of medications, things slow down, don't they? Because it's muscle, so it's going to slow down, and that's when you start seeing these little old people getting, and they'll get, what's it called? Constipated. Sorry. So you're going to do a real good assessment on them. What's the way we assess bowel sounds? Just like with the Foley, we can do I know, right? What else can we? How else can we assess the bowels? Listen. Very good. What's that called? Auscultate. Good. So we're going to use our stethoscope and listen to the bowel sounds in the 4 quadrants. Right upper, right lower, left upper, and left lower, right? So if I have my stethoscope, I do listen here, 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 and here, because I want to hear all of their vowels, right? And that way I can tell, are they bubbling? They sound like a pot of boiling water going off? Or are they very sluggish and slow? Are they high-pitched, like a, or are they real low, like a gurgling? So different vowel sounds mean different things. These are all the things that could be going on with your GI. Obesity, weight loss, fluid dehydration, oral hygiene. If they have bad teeth, are they going to eat much? Oh, it hurts. So then they're not going to have a good appetite. If they have gastric reflux, they tend not to eat because everything they eat hurts. So they just don't eat. Well, when we don't eat, our bowels slow down. Food intolerances, they might have allergies and stuff. They just can't eat it, or they don't want to eat, so they just don't eat anything. What about dysphagia? If you can't swallow and you're scared to death of getting choked and you live by yourself, are you going to be prone to eat much? That's why those little old ladies just eat like birds. They're scared to death they're going to choke and die in their home. And then all of those, constipation is kind of a side effect of all that. If you're not eating and drinking enough, you will get constipated. Meds, a lot of medications can constipate us. So these little old folks have trouble with that. Alright, I already talked to... For this chapter, it's page 1080 and through 1083. We haven't, I don't think we've gotten to it yet. This is all just the preface of it. We already talked about urinary and age-related changes. If your prostate's enlarged or you've had a lot of babies, that can change your anatomy and cause problems with your, like when you sneeze or laugh too hard. That's stress incontinence. A little trickle comes out, right? Yeah, it needs to get out. And so eventually it stretches as far as it can stretch, and it says, I can't hold it anymore, and it's just like a water balloon, it just lets it go. Okay. So, nocturia, it's not getting up and peeing at night, right? So it's just like a it's nocturnal urine. Peeing at night all the time. And then incontinence, we kind of talked about that. They're going to have different kinds. They all are caused by different things. Nocturia is peeing at night. Oh, I don't know where this... Hold on. Let's see. Oh, went too far. Hold on. I want 3 slides on this one for this. So, when you have a patient with colon problems, like I said, there's going to be lots of things that can cause colon problems, but lots of things that we can do to help it if they're constipated. Constipation just means it's abnormal or infrequent bowel movements, okay? Difficulty passing that hard, dry feces. This bowel has been sitting here full of rotting food, and they're not drinking enough, so it doesn't get flushed out. So that stool, that bowel movement, becomes hard. Have y'all ever seen dog or cat poo out in the sun? It's gross, right? It's dried out and baked. That's what is happening when you're severely constipated. The bowel very dried out stool. Okay. So we can give them things to try to help stimulate their bowels to move. Hopefully that will help, but if it's not relieved, then we have to get the fecal impaction out. And if it's too high, we can't get it. So here's your ascending, transverse, descending. So we go in rectally and we try to get it out. Now what nerve are we stimulating? Yeah, so we don't want to stay there too long. But if you can't reach in and you can't feel it with your 2 fingers, then it's too high up. You have to try an enema or maybe a laxative or something that you drink from the top and it flushes it downstream. Okay. Constipation can be acute, like it's a sudden onset. Something's happened, maybe they got hit in the bowel or hit in the stomach, like a student that was playing football got slammed and tackled, and that paralyzed his bowel. So all of a sudden, this kid who pooped 2 or 3 times a day, now he can't poop at all, and it's been a week because his bowel's paralytic. And so that could be an example of acute, or it could be chronic, like we said, little old people that are not eating and drinking enough, and they're taking medicines that keep them stopped up. Old people are very, very, very attentive. Elderly, I shouldn't say old people, that sounds awful. Elderly patients are very, very, very conscious about their bowel movements. They can come in and give you a CSI detailed report of every day's bowel movements, down to what color it was, how it smelled, the consistency, what was in it. That didn't look like that what I ate last night. They analyze it. They're very conscious about it because they're so worried about getting constipated because it does lead to other health problems later, okay? So that when they come in, you want to ask them about, when was your last bowel movement? They'll tell you exactly when it was, and then they give you. And then they will tell you, you're assessing too. Well, what color was it? What did it smell? Was it formed, like hard, or was it soft? Was it liquid? They can tell you all about that in detail. And so you want to be asking those questions too, all right? Even if your patient's in the hospital or a nursing home, you want to ask about that. First, when I'm listening to their bowel sounds, I take my ears out and I'm like, when was your last bowel movement? I ask every patient that because every patient should be having one daily. They need one daily, especially if you're in the bed, because laying in the bed we know slows it down, right? And if they haven't had one, it's been 2 or 3 days, guess what I'm going to go do? Make sure they got a high-fiber diet at lunch, and they're going to get a laxative or something, maybe a stool softener, if they haven't had one in 2 or 3 days. Okay? Okay.
She was on school, so
it just makes the difference between stool softener. It doesn't make you go. It just softens. It puts oil back in your bowel movement so that it's softer and easier to pass. An enema actually is water or something that's going to flush it out. But the stool softeners don't make them go. They're not a laxative.
so even if I was drinking water
You can still get constipated and bad enough impacted. Alright, so let's talk about what we can do as a nurse. Like Crystal said, they can give stool softeners, Colace. Should I make her drink plenty of water today?
Yes.
Yeah, fill that water jug up and tell her, you need this. Unless they're like on a severely fluid restricted diet, but increasing fluids helps the bowels move. A high fiber diet. What are some foods that are high in fiber? Oatmeal's good. What else? Bran. Raw fruits and vegetables. Man, just think of it. If it's raw and crunchy, the stomach's not gonna break it down, so it's just gonna chomp through there. It's like gravel. It's gonna pull all that stool with it, right? And so those are good. Fresh fruits and vegetables that are raw and crunchy, those are all good fiber. Like broccoli, carrots, something like that that's real bulky. Okay? Apples, an apple a day really does keep the bowel movements moving. Okay? Roughage, that's what they call it, roughage. Bran's good, like bran muffins or the bran cereals. They like those. They eat them every day. I used to laugh at my grandparents would go to their house. I was like, all they have is old people cereal. Because we wanted Captain Crunch or something. They have all the bran cereals. It was funny. Now I know why. Okay, what's another thing that you can give somebody to help their bowels move? Prunes! I got a prune story for y'all. Don't try this at home. I was working in an ER. I had been constipated. And so my friend Marjorie, she's a little old lady that worked in the ER with us, is a ER tech. She's excellent, very smart lady. She said, "You need some prunes." I said, "No, I don't. I don't like prunes." She said, "Oh, you'll love them." So she went and got me some on a break, and they were like those sweet-pitted prunes. They were just like a big raisin, which is just a plum, but they dehydrate. And so she sat on the counter, and we were busy, so we didn't eat, but we would grab a prune as we walked by every 15, 20 minutes. Before we knew it, the whole bag, she and I had eaten the whole bag of prunes. It was not funny. So I was like, "Marjorie, we ate all those prunes," and I was like, "My stomach hurt." Like I could feel it working already, you know. And she was like, "You'll be fine. Go home and sit on the toilet, and you'll be fine." And so I lived about 20 minutes away, so I got, it was 11 o'clock, I got off work, and I was like I could feel it moving, and it was loud and angry, and I thought, I'm not going to make it home. I'm not going to make it home. So I went back in to get a roll of toilet paper, because I thought, if I have to stop on the side of the road, I'll just have to. But I'm going to have something to clean up. So I was going to go snatch some toilet paper, and we get back up there, and the door's locked after 11 o'clock. So I was like, I need in. And I was clawing like a cat, trying to get back in there, and I ran in. They finally came and let me in, and I went into the bathroom. And when I got to the bathroom, it was locked. You know, it's that panic moment. You're like, and she comes, I hear a flush, and I'm like, oh my God, they're finally coming out. And she opens the door, and she comes walking out, fanning and whistling. I was like, oh my God, did you get in? She goes, well, I had to go. And so anyway, both of us had gotten cleaned out that night over a bag of prunes. So I can vouch for you, prunes work. 2 or 3 prunes is all you need, though, not the whole bag. Man, they work. So, like I said, if you have a patient, try to encourage them to eat foods. They don't know what high-fiber foods are, so you have to tell them, and you can always give them a couple of prunes on the breakfast tray. All right?
Is prune juice like this?
Prune juice is good, yeah, and that's fluids. So, but eating the actual prune, because it doesn't really break up, so it pulls that. It's just like, gravel, and it pulls that big bulky fiber with it, taking it all out. But they act fast.
I have a person up there who wants me to always go and get them milk
Warm
with
fruit juice.
and warm fruit juice and microwave it, and she drinks it like 4 times a day.
She wants her bowels to move.
And she poops like 4 times.
Well, she's going to dehydrate herself. She only needs 1 a day.
And she's on has a catheter. I'm like, oh, you need to stay away. They need to look at her more.
You can overuse laxatives.
She does
You need to
that.
get
She
dehydrated.
puts 2 medicine cups full. She wants a full. You got to show her that they're full.
Yeah.
And you put it in there, then you go and warm it up, and it is.
They love food.
Now, hot coffee, anything warm, somebody was asking about that warm produce, warm coffee, something warm in the morning, it relaxes that muscle in the bowel, and boy, it's like a freight train coming through. So they may want warm liquids. If they're constipated, you can give them a warm liquid. And that'll help move it. All right. Now, we know painkillers and antacids, those are stuff that can slow you down, constipate you, okay? Iron, if anybody's taking iron, that's a bad constipating med. So a lot of little old ladies are anemic, right? So guess what they get every day? An iron tablet. So we need to make sure that they're getting something to help their bowels move. If they're real bad impacted, when you're listening to the bowel sounds and you say, when was your last bowel movement, and they tell you, ask them, are you nauseated? Because if you're bad impacted, that stuff's backing up, so you are going to feel sick. That vagal nerve is being stimulated, and they'll be real nauseated. Okay. Like I said, fecal incontinence is just the opposite of constipation. It's coming out. They have no control over it. So let's say they have their health issues. I had something to erase with. X-rated. Okay, so here's your ascending, transverse, and descending colon. And then it goes down into the rectum here, okay? And that's where it exits the body. And here's your small intestinal in here, and stomach. So everything's coming through the chute. It's connecting here. It's ascending, transverse, descending, and then it comes out the body. Sometimes they'll have an impaction. Remember we said if the stool's right here, we can reach it with our fingers, we can pull that out. And then that hopefully unclogs them just like a clogged drain. And then the stool will move that's higher high though, let's say their impaction or hard, dry stool is way up here. I can't reach out with the fingers, so I'm going to give them an enema to help it get out. And then what happens, what you'll see is, every day, let's say you were off a week, you came back and you looked, and they're saying their stomach hurts, and they look real big and distended, and they're tight and they're hurting. And they don't remember when their last bowel movement is, so you go and look, and there's not one charted for 7 days. They're really high up. Well, then you get to talking to the nurse and pat them. You're like, oh, he just had some diarrhea. He's not constipated. Okay, you can have diarrhea and still be constipated. Because what is happening is this food that you're eating, that we're shoving down our patients for 3 times a day, is still going to go through. And what is happening is it gets right here, and it's liquidy, and it's like, oh, well, there's something right here in my way. And instead of, it can't go through because this is blocking it. So guess what it does? It goes around it. So they have seepage, and it looks like they're having a bowel movement, but it's diarrhea. It's because they're still impacted up high, and that liquid is just seeping around it. So if they're having excessive diarrhea, they need to be checked for an impaction. Because you can still be constipated / impacted and be having liquid, still real runny liquid diarrhea. They might be impacted. Suppository, you just put it in here, and it absorbs because we're real vascular. We have a lot of blood supply, and it's just a medicine in a solid form. So if they're unable to eat, let's say they're throwing up a lot, and they can't eat anything we put down, they throw it right back up, so they can give them a suppository. So those are handy, like if you're vomiting, they give vinegar suppositories, or if you're a baby and you need to give them Tylenol or ibuprofen, they can do the Tylenol suppository.
But they give, like, some of our guys, like, they have food,
They can give them it's a laxative. You can give them laxative. And so it absorbs, and it's picked up by the bloodstream, and then it stimulates that bowel to start squeezing, okay? And it helps move that out.
Are there any other things you can assess for to see if that's the situation or if they really are having that?
They will have, when you listen to their bowel sounds, it's going to be sluggish. This side will be like overactive, right? Because it's got all that liquid going. Blah, 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 blah. You get right here, it's like real slow, very, can't hardly hear anything. And then every now and then you'll listen long. If you listen, you'll hear, because it's air and stool or liquid trying to go around that. So it's a high pitch. So you may just hear, like I said, we'll listen to those Wednesday, and you can hear the difference. But that's why we listen to bowel sounds, and not just for a second.
What it sounds like when it's actually working.
When it's actually what?
When your bowels actually working.
It just sounds like a pot of water that's boiling real slow. Just a pop, 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 pop. We'll listen to them so y'all can hear the difference.
When I got sick, one week was after my treatment, and they talked to her, and she didn't poop for an entire month. And we took her to the doctor, and then it was stress-induced and everything. And we took an x-ray, and
She was packed full.
yes, and he said, so she's not going to poop anytime soon. They got rid of everything that we could get poop. And I have to give her a suppository in the morning, and then at night. And then I have to do that for 3 days. And then I have to massage her stomach with the warm compress. And then when she pooped, it was coming from the weightage.
They've been in there so long.
And I was like, and she just looked so scared, and she was like, honey, it's coming.
Yeah, it felt good, probably. Alright, so let's say, y'all look, I literally thought about this. Got my inspiration on the toilet. I was like, that looks like a bowel. So as I was changing the toilet roll out, because nobody does that in my house but me. Does anybody else have that problem?
Yes.
What is the deal? This isn't rocket science. Why can't anybody else do that? It drives me crazy. Anyway, so let's pretend like this is our bowel, right up here, okay? This part. Sometimes your patients will have diseased bowel, maybe cancer, or they've had an injury, I don't know, just something's happening with their bowel. And the doctor will do what's called a bowel resection, okay? So let's say this middle piece is our diseased bowel. They'll take this out. They literally go in surgery, and they cut this diseased bowel part out. And then they can sew it right back together, okay? So they've got that like that now. So your bowel's shorter, so you're going to have more frequent diarrhea, because you have less space to travel down. And then they'll take another section of bowel, not the diseased part, because they're going to throw it away. But they'll have another there's no way we can repair that and hook it back together, they can take another piece of bowel from another area, just cut off longer spot, and they can suture all this together and make it like that, right? So then it comes out to the outside of the body. And that's when they'll have a colostomy bag. So they'll put that right there, and then instead of the poop going out like it normally does, it's going into this bag. Does that make sense? Has anybody ever had a patient with a colostomy?
Yes.
It's clean, it is clean.
Yeah, it's rough. Not gonna lie, not a fun job.
I can't.
But it's again a body issue image. Who wants to walk around with that on them? No one would want that. But if you want to live, it's either have this or die from colon cancer. You know, you want this. So they have this, and it just attaches to the outside of the body. And like I said, that on the inside, the colon is actually coming through and emptying right into that bag. And you just have to be careful. They go on. It'll have a stoma. stoma, because a stoma can be anywhere in your body. It's just an opening. Remember, we have a trachestoma. You can have a colostomy, which is a stoma for the colon, or a urostomy, which is kind of like what I had to have, a bag with a catheter. So it can be any stoma, can be any kind of opening. But they'll have a colostomy. Again, you're gonna have to be real careful and watch for skin breakdown. This has to be cleaned up. I think they empty it several times a day because it's not gonna hold much. And these are like changed every 2 or 3 days.
Yeah.
Unless they just
They're
really
shower
gross.
days, and it gets full of air.
It's full of gas. And so, guess what you get to do? You get to tube for them. You open it up, and you compress it, and it's like, and it does smell bad. But, you know, they're as embarrassing and awful as it is for you, can you imagine how they feel? That's awful for them. So you put your nurse face on it, and you just pretend like it doesn't bother you. We used to take, I would have a spearmint.
We had one that had a catheter and he had a colostomy bag. When he'd get mad at us or we didn't do something he wanted, you just pull it off and you put it everywhere.
Because if they rip that off, it's an open tube, open colon, and so all that sewage is leaking out, right out. Okay, so this goes on there like that on the body, and you just have to do really good skincare and a lot of body image and teaching, because they're going to eventually go home and do this themselves. And some of them they used to roll up and had a clip. I'm glad now they have the kind that are self-sealing and have these little things that help. But they'll puff up. They're full of air. You have to open it and deflate it. And just, keep it clean. You can take them off and rinse them out because those are expensive. So it just depends on your facility, how many times they get them clean. Of course, if it's ripped or really in bad shape, you can always clean it because optimally our goal is to keep them clean and disease-free. And the last thing we got to talk about real quick is bleeding, GI bleeding. Just, has anybody ever had, you've had a really hard bowel movement and you go to wipe and there's little blood? That's okay. That's not really GI bleeding. That's probably where your stool was too dry and it just tore you a little bit, a hemorrhoid or something. That's okay. Because remember, this bowel is full of blood vessels, very vascular. So what happens is somewhere along the GI tract, whether it be the stomach, the intestine, or the colon, the large intestine, they've got an ulcer maybe, or something's there that's irritated, and it's just raw, like a scab, an open scab along the GI tract, and so it's bleeding. And so in their stool, when they poop, if you ever look at their stool, their bowel movement in the toilet, and it has blood all over it, or they poop and there's tons of blood, they get alarmed, right? That's scary. Bright red blood means fresh bleeding. And so they'll go to the doctor and they'll say, I'm having blood in my stool, and that would be GI bleeding. And so the doctor says, okay, I'm going to give you these 3 cards and 3 popsicle sticks. And they're called Hemocult cards. Hema means what? Right. So Hemocult, because we're going to do a sample that we're going to collect, and then we send off to the lab. So you have to get 3 different samples of that stool on 3 different stools, 3 different days. So day 1, they've gone home, they pooped that morning. Oh, there's bright red blood. They get their popsicle stick, and they get some stool, and they smear it on the little cards, there's little windows that they smear it on. Close it up, they put it on the counter. Day 2, they get up, same thing. They take some, smear it on the second card, and fold it up. Day 3, they get up, and they didn't have any blood in their stool, but they still have to get that 3rd sample. That's 3 days in a row. 3 stools in a row. You don't all get them on the same day because you could have diarrhea, and that's what's causing the blood. It's just irritated. So you get 3 different samples on 3 different days. Once you get your 3 cards, they bring them back to the clinic and they drop them off, and you get this bag of poo handed to you by the receptionist. It's great. When you open that, it smells good too. And you take this little solution and you drop it on there, and if it turns blue, it's positive for blood in the stool. So that's when your doctor would refer them to a GI specialist. That's probably when they're going to go get a scope done to see where that bleeding is occurring. Okay? But for you, the nurse, you have to explain that whole process to the patient. You get 3 cards. I need you to do 3 different stool samples on 3 different days and then bring them back to me. If they're having a lot of blood, remember we talked about volume. When you lose your volume, what do? You're losing blood, so is any blood going to get to your brain? So what are you going to have? Dizziness, confusion, maybe some anxiety. If they're bleeding a lot, their blood pressure is going to bottom, right? So get low volume. So you're going to be watching for all of that. Pallor, they'll be real pale because they're losing blood. Their heart rate might go up because they're nervous or they've lost so much blood they're going into shock. Okay? So you're just going to be watching for all that kind of thing and just teaching your patient about those chemical cards when they have GI bleeding. They could just be constipated, and they're, like I said, their idea of blood, I'm bleeding to death, and it's a smear on the toilet paper. That could be just they need to eat more roughage. They need more fiber. But if it's a lot that's bright red, then they definitely need to be seen by somebody. All right. We got 11:30 today. Here's your last thing. I'll let you go. This is just a handout for ways to promote normal elimination of the bowel. So that's going around. Positioning them. Is it easier to have bowel movement when you're laying down flat or sitting up? Sitting up. Okay? Or laying them on their side if they can't get out of bed. You know, rotating them helps the bowels move. Watching for output. How are we going to chart that? They had 2 bowel movements this 8-hour shift. How do you chart that? 2 times 2. VM times 2. And you're going to chart in your nurse's notes what did it look like, what consistency. We know fluids helps. What about privacy? Maybe they're still very private. I mean, I don't want to go to a public bathroom and let it rip. It's embarrassing, you know. So would you think your patient wants to be, you're standing over them, waiting on them to poop on that bedside commode? No. You give them privacy. Give them a few minutes. Maybe that they're holding it in because they're afraid if they let it go, it's going to be embarrassing. Okay? Exercise always helps. Get up, walk, or ambulate in the room or the hallway. And then this tells you how you're going to chart on it. The size, consistency, if there's any bright red blood noted, the odor, and then peristalsis is their bowel movements, like the bowel sounds, what you heard. Okay? So that's just one of your extras for your handouts. All right, y'all have a good day. I will see you in a little bit. I don't know if me or Red is going to be in here. It's probably both. Oh, here's a farm review. Yeah, go ahead and sign in, and then we'll stay in here. Did y'all need a farm review?
Yes.
Okay, I'm just going to stand at the door and hand them out. How about that?
Okay,
Go ahead and put it out. muscular when you bleed like crazy.
Yeah.
Is he okay?
Well,
Or was he okay?
he was in the ICU for a few days, just getting blood back, but then he was okay. Yeah, he was like, he told my grandmother, like, I'm having some blood in my stool. Can you look at it? And she looked and she said that it was like only